An osteotomy is a procedure, as I said before, where we realign the lower bones. It can actually be done from the age of 16 or 17, and usually the upper age limit's about 55. When we actually look at a knee, so when we actually look at a knee, and we've got a subject here, it's going to show you. Face the camera. And you can see our subject here, if they were to have what we call a bow leg, on both sides please. You can see in this situation, the bone on the inside, if you're a knock-kneed, starts to wear out, like so. Obviously it's completely the converse if feet apart. If they're what we call genu valgus, and they wear out on the outside of the knee joint, that's a lateral compartment. And this is what happened in my situation. She is now what we call varus, and there's a wearing out of the inside of the knee. What an osteotomy is an operation where they take a wedge of bone out, and the wedge of bone realigns. Instead of being a bow leg, it realigns it into a valgus situation, and so now the orientation is the outside of the knee joint takes all of the weight. Thanks. And this is again what we call an osteotomy. And there's different sorts of osteotomies that we can do. There is, like the osteotomy I've just had on my knee, this was called a high tibial osteotomy with a closing technique. And so the closing technique means they took a wedge of bone out on the outside, and they take a wedge of bone out like so, and then they realign it, and they put a very small little pin in there, and that's one technique. There's also a different type of osteotomy for my condition called a closing technique, called an opening technique on the inside. And in that situation, they have to do a bone graft. The problem with the bone graft and the medial operation compared to the one I had is that you need a lot more metal work, meaning that there's a lot more screws and metal work in there, meaning that down the track you have more likelihood of having metalwork irritation compared to the tiny little pin that I had. And the second thing is that at the 3-month mark on we call the opening technique on the inside, there's a higher likelihood of failure. So the lateral closing technique seems to be a much better option down the track in producing less complications, and additionally less likelihood of malunion. One of the reasons the surgeons don't like to do this technique I've had done is because we do have a perineal nerve that runs on the outside, and they're often scared that they're going to disrupt that, and the disruption of that can cause problems. It's technically a more difficult operation to do, but the results seem to be much better. The advantage of also the operation I've had done on the lateral side is that we're able to keep me in a knee brace like so I have good range of motion. And secondly, I can start weight bearing at the 2-week mark, about 10% of my body weight, and I can increase this by 10 kg a week over the preceding week. So it allows a quicker type of recovery. To be able to do an osteotomy, and the one thing I neglected to mention that we do need is that if we're going to realign the leg to put weight through the good compartment, you need to have a good compartment that's available, that's not worn out. When we looked at my knee on the x-ray, you can see from the x-ray, very worn out on the inside, very good joint space on the outside, and in fact the MRI indicated that my outside of the knee was in very good condition and could then withstand the new pressure that was going to be put through the outside for the next 20 to 30 years. The data on the operation I've had, which we call the, as I said, the closing technique on the lateral aspect, is that at 10 years, there's a 97% likelihood I'll have no pain and good function. And at 20 years, there's a 70% chance, which are pretty good stats when you think about it. I'll be close to 76, almost 80 years of age in 20 years, and there's a 70% chance I will have a fully functioning pain-free knee. Now, one should also realise this is not without specific post-op instruction. The operation I've had done, the osteotomy, I'm advised not to go back to level 1 sport, including basketball, netball, soccer. I'm advised not to go back to running as well, distance running, but I can play tennis with the kids. I can go skiing. I can do these sort of activities which are low impact. So again, when we're looking at these sort of operations, they're not the silver bullet to produce a perfectly functioning knee to go back to any activity. They're an operation that allows us to go back to high level activity, but not all activities. We additionally, as I mentioned before, know that patients long-term wise with this sort of operation do much better if they, again, as we said, were below the age of 55, if their BMI is below 30, and also if they don't go back to these high load activities. In summary, we think osteotomies are a great operation when there is definitive joint space reduction shown by a weight-bearing series of x-rays in one of their compartments, only one, and the other compartments are well maintained. We additionally know that, again, the age is really important, that you are not over the age of 55. But conversely, bear in mind, this is an operation that we've had performed on patients as young as 16 to 17 years of age. And I'm going to speak briefly about one girl we had who had 3 partial meniscectomies. They trimmed the inside of the meniscus, 3 of them done by the age of 16, 3 different surgeons in Singapore. At 16 years of age, she had a knee joint that was not too dissimilar to this. At 16, her growth plates had closed and she was getting pain. What option was available for her for the rest of her life? An osteotomy, good operation. The growth plates have changed, so have closed, so it meant that we could then redistribute the weight onto the outside of the knee, in making it a little bit more knock-kneed. And in fact, to date, I followed this girl up now 15 years down the track, and she continues to be asymptomatic. So it's also an operation we should consider, even with the younger athlete, as a plausible option. The reason I'm doing this video is to try and educate the general public that there are other options other than physiotherapy, a clean out of the joint, a joint replacement that are available to patients. And this is a very good discussion to have with well-educated and informed surgeons. So I'm trying to, again, give good information to the general public to talk about this operation, which is a little bit out of fat at the moment, but the results we've had have been sensational. And I guess to finish with, I'm probably a good example of this. I'm a physio and have been for 30 years. If I'm willing to go down and do this sort of operation, it shows you the faith that I have in the medical team, the faith I've got in them performing this, and also the long-term effects of this operation as well. Thank you.